Hello and welcome to my advanced herbal medicine presentation. So our client today is a 23-year-old female who presented to the clinic with severe premenstrual syndrome, which began 1 year ago after ceasing the oral contraceptive pill. She's experiencing tender breast, irritability and anxiety leading up to her bleed, and during her bleed she experiences heavy bleeding, fatigue, bloating and large clots. Her current job requires shift work and she's only getting 4 to 5 hours of sleep per night. This is likely disrupting her circadian rhythm and cortisol levels. There is family history of PMS, PMDD, and dysmenorrhea. For this client, her severe PMS symptoms during the luteal phase, days 15 to 28, reflect estrogen dominance and progesterone insufficiency, which have been shown to disrupt GABA and serotonin activity. Shift work disrupts the HPA axis, spiking cortisol, impairing HPO axis function. The suggested approach for this client is focusing on detoxification and hormonal modulation to alleviate PMS symptoms while also addressing HPA axis dysregulation by supporting the body's stress response. So predisposing factors in this case include family history of PMS, as this makes the client more susceptible to PMS due to hereditary factors. The client's gender, being female and of reproductive age, as well as working as a high-stress job, are also predisposing factors. Excitatory factors include recent cessation of the OCP, excessive caffeine intake, her high-stress shift work job, poor sleep, and disrupted circadian rhythm, which can all exacerbate symptoms. Cessation of the OCP may lead to HPO axis dysregulation, which can alter estrogen and progesterone balance, potentially exacerbating PMS symptoms. High caffeine consumption can increase cortisol levels as well as increase burden on the liver, impairing estrogen metabolism, therefore resulting in excess estrogen in the body, therefore intensifying symptoms of PMS. Chronic stress from shift work can dysregulate the HPA axis, leading to heightened cortisol levels and impaired HPO axis function, as shown in the diagram on the right. In addition, inadequate sleep and disrupted circadian rhythm can interfere with neurotransmitters such as GABA and serotonin, which can exacerbate symptoms associated with PMS. Caffeine intake is again a sustaining factor for its impact on cortisol and the liver. Additional sustaining factors include poor fiber and water intake leading to constipation. This constipation can then lead to the reabsorption of toxins and hormones such as estrogen via the gut. This increases recirculation of estrogen and can further exacerbate PMS symptoms. The client's high intake of dairy and refined carbohydrates are also sustaining factors, elevating systemic inflammation, which can worsen PMS symptoms. She also has a very low omega-3 intake, which can lead to an increase in the production of pro-inflammatory prostaglandins, contributing to hormonal dysregulation. So some of the differential diagnosis for this case include PMDD, as her psychological symptoms of irritability and anxiety could be indicating this. However, she does not meet the DSM-5 criteria. She's also experiencing a hormonal imbalance, likely estrogen dominance, which is driving her symptoms of breast tenderness, irritability, anxiety, and heavy menstrual bleeding. Hypothyroidism is another potential diagnosis due to her fatigue and constipation. However, she is not experiencing any other symptoms at this stage. She is experiencing constipation, as I just said, likely contributing to a hormonal imbalance. She's also experiencing chronic stress, leading to HPA axis dysfunction. So the primary diagnosis for this case is premenstrual syndrome, also known as PMS, which is defined by cyclical symptoms in the luteal phase, which is days 15 to 28 of the menstrual cycle, which resolve with menstrual flow. The client's severe PMS manifests as breast tenderness, irritability, and anxiety. On the right, you can see the PMS tissue states this client is presenting with PMS-A. Although the etiology of PMS is uncertain, hormonal imbalances, particularly estrogen excess and progesterone deficiency, are key factors. A sensitivity to estrogen and progesterone imbalances disrupt GABA and serotonin pathways, causing psychological symptoms such as irritability and anxiety. Excitatory factors such as recent oral contraceptive pill cessation and chronic stress exacerbate HPO axis dysregulation, with constipation increasing estrogen absorption. So here are our clinical priorities for our client, addressing both physical and psychological symptoms within 2 to 3 cycles. Firstly, we aim to promote regular bowel motions to reduce estrogen recirculation. This will be tracked through a bowel log and also less occurrence of bloating. Secondly, we aim to alleviate breast tenderness by lowering inflammation to improve everyday comfort and functioning. This will be monitored with a symptom diary. Thirdly, we aim to reduce heavy bleeding to prevent iron deficiency. That will be measured by a pad and tampon count. And fourth, we aim to regulate the HPO axis, supporting a healthy estrogen to progesterone balance to eliminate PMS symptoms, and this will be measured by cycle diaries. Then we can aim to enhance digestive and hepatic clearance for long-term hormonal balance, assessing bowel motions, bloating, and energy levels. And finally, we aim to support the stress response, stabilizing GABA and serotonin to reduce anxiety and irritability, monitored through sleep and stress logs. These priorities, supported by herbal interventions and dietary changes, aim to restore balance holistically. So here are our short-term aims for this client. Firstly, we aim to increase bowel motion frequency with depurative and bitter herbs, reducing hormone reuptake and addressing constipation and bloating. Secondly, we'll reduce premenstrual breast tenderness with hormone modulating and anti-inflammatory herbs. Third, we aim to reduce the severity and duration of heavy menstrual bleeding to lower anemia risk using hormone modulating, anti-hemorrhagic, spasmolytic and anti-inflammatory herbs. Finally, we aim to support the HPA axis function with adaptogenic and calming herbs to reduce stress-related symptoms like anxiety. Now, our long-term aims to achieve sustained PMS symptom resolution. Firstly, we aim to support and maintain HPO axis regulation to maintain balanced estrogen and progesterone ratios using adaptogenic and hormone modulating herbs. Second, we aim to enhance digestive and liver function for optimal detoxification and hormone clearance using bitter and hepatoprotective herbs. So here are our chosen herbs. We have Vitex agnus castus, also known as chaste tree, Silybum marianum, or milk thistle, Taraxacum officinale, or dandelion root, and Peonia lactiflora, also known as peony, and lastly, Withania somnifera, also known as ashwagandha. So we've also got our doses on there, so 10 mils, 45, 30, 45, 30, which are kind of in the middle for our client. So our first herb, Vitex agnus castus, is key for our patient's severe PMS symptoms. Vitex acts as a prolactin inhibitor, reducing elevated prolactin levels via dopaminergic effects, which support ovulation and luteal function, which can ease breast tenderness. As a dopaminergic agonist, it stimulates the hypothalamic dopamine receptors, decreasing prolactin release, which can help with mood changes. Additionally, its indirect progesterogenic actions enhance luteal phase progesterone, reducing estrogen dominance, addressing old PMS symptoms. The active constituents include flavonoids like casticin, diterpenes like vitaxylactone, essential oils and glycosides all drive these effects. Safety-wise, Vitex must be avoided with the OCP or progestogenic drugs due to hormonal interactions. There is also the possibility of nausea or headaches, so this will just need to be monitored for this client. The next herb is Silybum marianum, which will be used to enhance liver hormone clearance, helping to reduce the client's PMS symptoms. As a hepatoprotective herb, the silymarin in Silybum protects liver cells from numerous toxins, including caffeine, and supporting detoxification. The herb's tropho-restorative actions help to restore liver function, which is essential for optimal hormone balance and estrogen metabolism. The herb also acts as a choleretic, with the flavolignans silicristin and silidionin stimulating bile flow, which enhances excretion of hormones such as estrogen via the bowel, in turn also reducing PMS symptoms as well as heavy bleeding. Finally, Silibum's antioxidant action is driven by silimarin's flavolignans as well, like silibin, these neutralize free radicals and reduce systemic inflammation as shown in the diagram to the right. This will support the reduction of PMS symptoms, including breast tenderness and fatigue. Silimarin also enhances phase 2 liver detoxification, which is extremely important in this case for the clearance of estrogen. Safety-wise, this herb is to be avoided in Asteraceae allergies. It is also important to monitor iron absorption as it has the potential to lower this. The next herb is Taraxacum officinale, used to manage the client's PMS by supporting the gut-liver axis, targeting constipation, bloating, and breast tenderness. As a bitter tonic, Taraxacum stimulates digestion and peristalsis through sesquiterpene lactones like taraxacin, promoting regular bowel motions and reducing bloating. Its mild laxative effects enhance bowel motility through bile flow, also promoting regular bowel motions. Supporting regular bowel motions in this client's case will further support estrogen clearance, easing breast tenderness. Its cholagogue action stimulates bile drainage, also important in clearing and metabolizing estrogens, supporting the reduction of heavy bleeding and constipation. As a key constituent in this herb, inulin supports gut microbiota, reducing inflammation and also aiding in regular bowel motions. The phenolic acids and triterpenes present in this herb are beneficial in this case with their antioxidant and anti-inflammatory effects. There are no safety issues identified relevant to this case. Next, we have peony, a herb we are using to target breast tenderness and heavy bleeding. As an estrogen modulating herb, peony helps to balance the estrogen-progesterone ratio through regulating LH and FSH levels via the HPO axis. This in turn supports ovulatory function and progesterone synthesis, useful in addressing luteal phase insufficiency and symptoms associated with estrogen dominance. This herb also displays anti-inflammatory actions through flavonoids and peonyflorin, which can reduce breast and uterine inflammation, which in turn can ease the breast tenderness and bloating this client is experiencing. Peony also acts as a spasmolytic, relaxing uterine smooth muscles. Active constituents like tannins and albiflorin further support hormone balance, reducing heavy bleeding. There are no safety issues relevant to this case. The last herb we have is Withania somnifera, used to target her anxiety, irritability, and fatigue, as well as support the HPA axis. As an adaptogenic herb, Withania modulates the HPA axis, stabilizing the HPO axis to reduce stress-related PMS symptoms. It also has anti-inflammatory action through withanolides like withaferin A, which downregulates cytokines, reducing breast tenderness. As an antioxidant, this herb protects endocrine and nervous tissue, which can help to reduce fatigue. It also possesses anxiolytic effects through alkaloids like tropine, calming the nervous system to further lower anxiety and irritability. There are no safety issues relevant to this case. So here we have our anticipated changes over the next month for the client's PMS management using the herbal interventions. Firstly, we expect to see her bowel motions increase to at least once daily with reduced bloating and improved bowel consistency, addressing constipation. Secondly, we expect to see at least a 25% reduction in PMS symptoms severity and frequency, including breast tenderness, irritability, and anxiety. Third, at least 20% reduction in menstrual flow and clotting. Lastly, we anticipate better sleep quality and lowered stress levels, sleeping at least 7 hours per night. Here we have the 10-year prognosis for our client if her PMS is left untreated. Unaddressed sluggish motility and constipation could worsen estrogen reabsorption, driving systemic inflammation and PMS symptoms. This may then lead to estrogen dominance, increasing the risk of endometriosis and fibroids, with worsened breast tenderness and heavy bleeding. With endometriosis being a leading disease in females aged 25 to 34 and on a steep increase as seen in the chart to the right. This continued heavy bleeding may lead to iron deficiency anemia with subsequent fatigue, a leading disease in females of this age as well. Unrelated stress and psychological PMS symptoms may progress to anxiety, depression, or burnout. Depression and anxiety also being leading diseases in females aged 25 to 34. Lastly, recurring PMS and low energy could impair the client's relationships, job performance, and overall well-being. This highlights the importance of addressing the client's PMS holistically to avoid this. Thank you so much for watching, and on the following slides are my references.